Welcome to a very brief discussion of ITCT-A, which is also available in more expanded form, as you'll see in the handouts or on the slide presentation through our website. You can download both the manual for the ITCT-A in general, as well as a specific manual for treating substance abusing or using multi-traumatized adolescents. ITCT-A is an intervention that's been crafted to try to address, and hopefully does address, the complex impacts of repeated trauma, usually trauma that began very early in life and continues on into, in this case, adolescence, although adulthood as well, unfortunately. There are many long-term lasting outcomes of repetitive, long-term, often quite intense trauma. You see on this slide just a brief overview of a lot of those. Anxiety is very prevalent, as is depression. These will not always manifest as someone having a disorder per se, although they often do. They may just present as free-floating anxiety, dysphoric mood, people having trouble within and between sessions associated with panic, other kinds of difficulties. Anger is a very clear and relevant aspect of ITCT-A targets for adolescents, because often young people who have been repeatedly victimized are carrying around a fair amount of irritability and anger associated with how they've been treated, as well as, in some cases, the secondary effects of hyperarousal associated with PTSD. And actually, addressing anger is a big deal. Because a lot of our treatment models don't really tell us much about what to do with that presentation, and yet it's very common, as a lot of you know, in traumatized youth. So we need to pay attention to that, even though there's no actual DSM disorder covering anger per se, as opposed to anger behaviors, perhaps. Post-traumatic stress is obviously prevalent in a lot of these kids, although, you know, it's important to note that it's post-traumatic stress listed here, not PTSD. That's because many kids, especially kids who have been in chronic trauma situations, whether it's gang-related, sex trafficking, sustained childhood trauma associated with physical or sexual abuse in the family, those individuals will have some post-traumatic stress symptoms. They may or may not meet all the criteria of DSM-5 PTSD. We generally recommend that you treat the presence of post-traumatic symptoms as a major target, irrespective of whether the person actually has PTSD or not. Affect dysregulation, as you know, is a growing interest in treating complex trauma, because what we're beginning to understand is that an awful lot of people started being hurt very early in life through acts of commission like abuse, but also acts of omission like early unavailability of parental caretakers, psychological distance between the caretaker and the child, etc. So when you have neglect kind of effects, as well as early trauma effects, what you tend to get is problems in the development of abilities to regulate your emotional experience. So kids without optimal child rearing experiences will often have troubles calming themselves down, decreasing or downregulating powerful negative emotional states associated with trauma. And when that happens, they tend to have to engage in other activities to take over the job of their affect regulation problems, which we'll talk about under avoidance responses in a second. Also, what we see is a lot of negative schema. Schema refer to beliefs, assumptions, expectations, and in some models, the emotional stuff associated with that. And generally what we see with multi-traumatized kids is that they tend to have very negative views of themselves in terms of low self-esteem, helplessness, hopelessness, and also have relational schema problems in terms of viewing others as very dangerous when they may not be. They have difficulties in regulating relationships because of the assumptions they make, and because they're using strategies that may have been helpful early on in life, but may be more problematic later on when they are trying to form connections with other people. Because humans need to connect so desperately and powerfully, relational schema problems can produce very unhappy people. And so I'm sure you've seen a lot of kids who are feeling isolated, angry, alone, and maybe desperate for connection. They may either be avoiding people because they know they'll be hurt, or they may be actually too open to interactions with people and somewhat desperate in their relationships to them, which may actually increase the likelihood they'll be victimized under certain circumstances. Avoidance responses are really the effect of both the distress that people feel associated with the trauma and then their inability to regulate that distress. And a lot of us have spent some time working out that dynamic. So for a lot of kids, there'll be a lot of abuse-related pain and distress, but there'll be relatively few internal capacities to regulate that distress, what we call affect dysregulation. As a result, what the kid has to do is find some way to solve the problem of pain that exceeds capacity to handle pain. This is a recipe for desperation. If you feel more anxiety or anger or whatever, then you have capacity to regulate those states. You'll have to find something, either some kind of coping response or some kind of behavior in the environment that allow you to downregulate or handle the distress that you're not able to regulate normally the way that a lucky kid might be able to in the context of a caring environment. So you just see a few of them there. We have a lot of things to talk about, so we won't talk about this in too much detail, but dissociation means a defensive alteration in awareness. So kids may space out, zone out. They may have periods of experience of unreality. They may feel alienated from their own bodies and minds. They may space out. And sometimes they have more severe dissociative responses, which may involve decreased memory for very distressing material. Sometimes the experience of multiple personalities, although we tend to see that more in the older adolescents and adults. It can be present in children, of course. Tension reduction behaviors, which just means any external activity you engage in as a way to reduce painful internal states. So we see this with an awful lot of multi-traumatized adolescents. They may engage in activities that distract them or soothe them or produce incompatible positive states. So they feel some positive feeling as a result of their behavior, and it neutralizes, at least temporarily, the negative feelings they're also having. And some are just frank avoidance responses where you have less access to actual painful internal experience. And you just see a few listed there. We could go on about that. Self-injurious behavior, which we're very interested in and done a lot of recent research on, which is intentional self-harm without direct suicidal intention, typically cutting on your arms or legs. In the past, burning, less burning now that cigarettes are less commonly available to the youth. But some kind of self-hitting, poking one's eyes, pulling out hair, etc. These are all ways probably to sort of wake oneself up from dissociative reactions that one might be having, numbing responses, as well as self-punishing and other kinds of behaviors. We also see excessive or inappropriate or somehow dysfunctional sexual behavior, wherein the adolescent is using sex as a way to actually decrease their painful internal states as opposed to any other more relational reason. Bulimia, binging and purging, aggression, which again in a lot of the youth that we see is a big deal because they're involved in some kind of aggressive experiences, including gang activity or just being very easily prone to getting into fights, etc. And of course the ultimate avoidance response is a behavior is suicidality, which is attempting to kill yourself or killing yourself as a way to get out of painful internal states. Sometimes suicidality is a way to get, quote, attention or to change relational context, but it still relates to a desire to change one's emotional state by engaging in some kind of avoidance strategy. We make a big deal about substance abuse in ITCT-A, not that every adolescent with trauma histories are involved in that, but a substantial number are. And actually we, again, as I mentioned earlier, have a manual just on treating substance use and abuse issues, primarily because a modern trauma perspective on treating substance abuse related to trauma, in fact, looks a little different than the classic substance abuse treatment models we have up there. And then it looks like I've said suicidality twice, I guess, to reinforce the point. So ITCT-A has certain core aspects, so let's just describe those very briefly. But an important notion here is that These are the overbridging perspectives one uses when dealing with youth. Then there are the specific interventions of ITCT-A. Often these kids are very challenging, and they can activate our own emotional responses and baby childhood histories ourselves. It's good to have sort of an overriding view of what we're doing here. So let's just talk about the central notions here. The first one is, and I hope this isn't off-putting, because some people, when they hear the word assessment, they imagine that that will be very rigorous and difficult and maybe somewhat disconnected from the child's experience. But ITCT-A's assessment-based focus just means that you're keeping track of the major issues that the kid is experiencing so that you can then craft your responses so that they directly address those specific problems. So if you have one kid who's cutting on herself and dissociated, you've got another kid who's having flashbacks and nightmares, you've got a third kid who's very preoccupied with attachment and very fearful of abandonment, et cetera. Those kids are all going to need different kinds of intervention. And so an important aspect of ITCT-A is that we talk about customization, which I'll mention in a few minutes, which means that every kid's going to need a slightly different treatment because this is a multimodality intervention. You're not going to use so much, for instance, exposure therapy in a kid whose primary issues are preoccupied attachment difficulties. And if you have somebody with flashbacks, probably exposure is going to be more helpful than perhaps some kind of a narrative response or some other kind of intervention. So we try to adjust treatment for the specific issues. That requires some level of assessment. This does not mean paper and pencil-based psychological tests necessarily, although it's good when people use those. We'll see in a couple of slides that we have something called the Assessment Treatment Flowchart, which is just a series of items that the clinician, not the client, kind of checks in on in terms of how the kid is doing every couple of months so that they can monitor the effects of treatment so that we can figure out whether we need to stick more with one intervention module or whether we can move on to another one, whether some problems are resolving. Maybe some are getting worse. Very complex course for many kids. Tends to focus well beyond post-traumatic stress. This is not to say that post-traumatic stress isn't one of the most painful aspects of trauma-related outcomes. It's just that for many kids, there's much more than just PTSD going on. They may have problems in their relationships with others, which again, for humans is a big deal. We need to be loved, we need to love, we need to connect, even among alienated and shut down people. That is an internal, pretty much hardwired desire that we have. So kids whose relationship with others are being distorted by their expectations that life will be like it was when they were an abused child may mean that they have lots of chaotic, crisis-laden, intensive, short-term, sometimes relationships with people, and that may not technically fall under the rubric of post-traumatic stress. As you mentioned earlier, a lot of affect regulation problems in these youth. Many of them started being abused or neglected very early in life, so they were deprived of the opportunity to develop affect regulation skills. So what we're going to want to do is somehow increase their affect regulation. But fortunately, in this regard, there are a number of modalities available in the empirically based literature on how to increase adolescent and adults' affect regulation skills. And then, although we wouldn't want to characterize it this way directly, a lot of people sort of think of ITCT-A as especially helpful in working with, quote, acting out or shut down or other multi-traumatized kids who have a lot of problems with dissociation, substance abuse, tension reduction behaviors, et cetera. So we do focus a fair amount on those issues. They may not actually be directly related to post-traumatic stress, and they may not respond to interventions that are crafted just for PTSD or post-traumatic stress. Another central idea here, and this is in some contradistinction to some of the other models out there, is the centrality of the therapeutic relationship. If you look at the psychotherapy outcome literature, it's pretty clear that the general factor, the factor of the quality of the relationship between the client and the therapist is quite important in predicting outcome. The better the relationship, the more compassion, tuned responses the therapists have, the better the fit between the therapist and the client. Those kinds of issues are are going to be very prevalent. And so in ITCT-A, we actually, and you'll note this in the treatment guide, that we spend some fair amount of time working on articulating the specific issues that need to be reinforced and connections need to be made between the often alienated and sometimes quite angry or internalized withdrawn sort of responses. And so what we want to do is develop some kind of connection there. Since a lot of these kids have attachment problems, it may not be quite as simple as it might appear when working with people who are lucky enough to have more benign early environments. We focus a lot on safety. You'll see that the ITCT-A interventions focuses on safety first. You know, if you're working with lucky kids in more benign environments, they may be relatively safe. They may be safe in their homes. They may be safe in their neighborhoods. But a lot of the kids that we see, especially because a lot of the kids we're working with are socially marginalized and live in poverty and face different kinds of discriminatory social behaviors, they may not be safe. It's very common for an ITCT-A adolescent to have experienced neighborhood violence, violence in the home, etc. So we focus a lot on that, both in terms of monitoring their safety through assessment as well as trying to intervene with safety plans and other things with them in a very explicit way. You know, it will not help if your client is getting better in therapy, but they're actually also at risk of being badly hurt or even killed in that environment. So we focus on safety first. As I mentioned earlier, we try to customize ITCT-A. So you'll notice in the manual that we have adjustments for the age of the kid. As you know, a 13-year-old adolescent and a 17-year-old adolescent have a lot of differences as well as commonalities. So we want to make sure we attend to that. Gender is a very laden issue in our culture. There's many ways in which gender roles and social differential responses to males versus females means that we have to pay attention to whether this kid that we're working with is a young woman or a young man, the issues they may be struggling with, their greater risks for different kinds of victimization. And their ways of responding to therapy are going to be quite different, at least in some cases, between males and females. We focus a lot on culture, as you'll notice, and if you go to ITCT-A, go to ISTSS or other conferences where ITCT-A is being presented, you'll note that we will often have adaptations and speakers who focus on adapting some of the ITCT-A things for different cultures and different ethnic groups, who may have different experience of trauma, different expression of trauma, may have to respond to trauma in different cultural contexts. And then, this is a fairly common discussed issue, which is if you do have a kid who has affect regulation problems, it may be that you want to make sure you don't flood them with too much emotional material too quickly. You may not want to have them drop right into intense and prolonged exposure when they don't have much ability to regulate the emotional responses to what happens when they experience exposure. Exposure interventions are very important in ITCT-A as well as in obviously the other major, at least some of the other major treatment models. But we talk more about titrated exposure here, which is that you make sure that whatever the client is processing doesn't exceed their capacity to handle the distress that may arise when they process that material. So we're going to want to both A, make sure that what the kid is dealing with is what they can handle, and B, we're going to be trying to increase their ability to handle more so that as time goes on, their therapeutic process tends to speed up and become more effective. This is obvious. You wouldn't normally want to do this. We want to avoid judgmental or authoritarian therapist behaviors, but especially if you're working with socially disenfranchised youth who've been maltreated by people that look an awful lot like the therapist, or in the context of parental authority that's been misused, that what you get is what we might call authority issues in children, in adolescents, but really it's just that there are a lot of triggers in therapist behaviors which can activate the child or the adolescent's distress associated with how they've been hurt in the context of authority and judgment in their home, in their environment. So we work very hard to not be very authoritarian with our clients. We emphasize their capacity to decide what they want to do, when they want to do it, how much to do it. We don't make a lot of hardcore interpretations or other things that tell them that we know and they don't know. spend a lot of time trying to deal with these power issues on one level or another. We also, unlike some models, we focus a lot on advocacy and system intervention, so there's nothing wrong from the ITCT-A perspective, the therapist dealing with the school system, probation system, or other criminal justice kinds of domains, welfare, whatever it might be. So there can be quite a range of hands-on interventions that the therapist does that may be outside the normal realm excuse me, of classic ITCT-A therapeutic interventions. Okay, I'm trying to make it advance here. This is the assessment treatment flowchart. It's called the ATF. The ATF actually has two versions because there's also a child version of ITCT. It's called Integrative Treatment of Complex Trauma for Children, and that is the ATF-C. This is the ATF-A, which is the one used for adolescents. Basically, as you'll see if you go to the website for ITCT-A, that you can download the initial trauma review questions that can be used for assessment that allow you to get a good sense of what's going on with this kid. And then what you do is at intake and every couple of months or even faster if you're seeing them for a shorter period of time, you rank the child's or the adolescent's difficulties with one of 17 or 18 or 19 different problems that you're going to rank each. You're going to rate each couple months. So for each symptom or problem, you'll probably rank it as a 1, a 2, a 3, or a 4, with 1 being it's not really a problem right now. 2 is a problem that I don't have to deal with it right this second. 3 is a problem and I really need to work on it. 4 is it's emergency or very problematic, requires immediate attention. So let's say that the client had self-injurious behavior, but it rarely occurs and it doesn't seem to be a big problem. You want to address it, but you probably wouldn't give it a 4 right away if it wasn't what was really the problem at the moment, like perhaps great vulnerability to victimization or aggression towards others or suicidality. So you rank this on a 1 to 4, and then we added later, in response to clinicians, a lot of people thought that probably something was going on with a given symptom, but they couldn't actually guarantee it, and they didn't know how to rate it. So we now have an S along the 1 to 4, which is, I suspect something's going on. Let's keep on looking at it. Here you just see, this isn't actually how it looks, especially that skewed second item there. Here you see how an ATF might sort of look. So you look at, for each, there'll be like a 2-page little thing that lists these various problems, and then you rate the treatment priority at the given moment for each of these problems. So if the kid right now is stuck in prostitution or is in a gang environment or is in an unsafe home environment, for instance, for item number 1, you might rate that a 4 because safety, again, is our biggest concern. Note that treatment priority doesn't mean intensity of the problem. You may have someone who has a fairly intense problem, but the ATF is more about triaging, figuring out what does this kid need right now, because a lot of the kids we see have a lot of problems going on. What are the most acute problems? How do we figure out how to intervene with that specific acute problem? So you might, for instance, low self-esteem, number 6, it might be rated as a 3 initially, but later as other problems get resolved, you might want to work on that more acutely, and that would become a 4. It wouldn't necessarily mean because self-esteem had improved, just mean that your decision to work on it had gone up in priority. Usually ATF items do correspond to intensity, but again, remember that what we're looking at here is this is like a treatment planning algorithm. It's saying what do we need to do in the next few sessions. We're going to then retest you in another month or 2, again, just by asking you questions to reassess where you are on these things so that we can make mid-course corrections and say, you know what, post-traumatic stress seems to be decreasing, but self-injury isn't changing, and I'm more worried about self-injury now, therefore I want to focus on it right this second. Or maybe the self-injury has gotten more severe. So the ATF is basically, in some ways, a treatment planning model, but it also involves, obviously, ongoing regular assessment. Issue, a thing to talk about is the problems to components grid. What this basically reflects is that when you completed the ATF-A, you're going to then have certain problems prioritized over other kinds of problems. The Problems to Components Grid, or the PCG, which you can also download, allows you to look at each problem that you rated highly and then what in the empirical literature has been shown to be effective for that problem. So that means that, say you had safety problems, we have a component on safety training, systems interventions, psychoeducation, et cetera, which may be very important for safety in that case. On the other hand, if there are issues with uninvolved parents and non-supervising or non-protective parents, we may want to focus more on family therapy, et cetera. So the Problems to Components Grid is going to take you from the results of the ATF to the specific components of ITCT-A, which are going to be most helpful. Typically, each of those components is a separate chapter in the treatment manual, so we're going to want to go from the PCG to the components themselves. So let's just very briefly, and we don't have a huge amount of time, let's go over the general treatment components. Each of these is typically, again, another chapter in the manual. The idea is the ATF tells you what to focus on, the Problems to Components Grid tells you where to go next, and which chapter, and then which intervention to use. These are all relatively discrete, but of course in any given session you may be using a number of these components. We don't necessarily suggest a stepwise approach because different kids may need different interventions at different times. And I'm going to just basically mention these, not talk about how to do them because that would take much longer than the time we have, but to refer you also specifically to the manual for these interventions. The first one is we're going to want to work on relationship building and support. This involves doing whatever is necessary to cause the youth to feel connected and attached on some level to the therapist. The therapist is responding in an accepting, caring way and is showing compassion towards the youth. Many of these young people have had very little loving, boundary-specific but caring interactions with authority figures. This becomes a very important thing, not only for making them feel better and feel more grounded and cared for, but also because, as I mentioned, the therapeutic relationship is one of the biggest predictors of therapeutic outcomes, so we want to really build that, the relationship. And you'll see that we actually, in that chapter, have a number of very specific targets for developing relationships and what the clinician can do to increase them. Another is the MOD safety module, which is basically we're trying to do two things. We're trying to see if we can improve the child's environment, either by intervening in that environment or by maybe having them be in a different environment. So some of this has to do with danger in the outside world. Is your pimp violent with you? Is your drug interaction, so you're getting hurt? Are there gang things going on? Is your father acting in a way that is frightening to you, or your mother? So we spend some time working with them on a regular basis about assessing what the dangers they might have, but then we also figure out things they can do. So safety plans, where could they go to be safe if they think they're in danger? If they were suicidal, could they tell people about that before the suicidality gets really severe? For older adolescents, how could they engage in safer sex, both in terms of being stuck in the sex trade, but also just in the sexual interactions we see in a lot of abused and maltreated adolescents, which may mean that they aren't using condoms, they're not actually protecting themselves in various ways in sexual interactions. So we want to focus on that, and that's actually an explicit part of ITCT-A, that kind of attention to detail. How can they get help with substance abuse in an acute sort of way? Are there referrals we can make for other people who can help them with substance abuse? Obviously, you want your client to stop using drugs, but it may be that drugs are serving a very powerful function for them in keeping distress down. And so the negotiation of how you reduce substance abuse in adolescence is a big deal. That's why we have a separate manual on that. ITCT-A deals a lot of times with gangs and prostitution. It may not be what you would be dealing with your adolescent if you're using ITCT-A, but because we work a lot with socially disempowered, socially marginalized, impoverished kids and their families, these issues come up over and over again. Not even to say, by the way, that gangs, for example, are necessarily just prevalent in lower socioeconomic groups, but clearly a lot of the kids that we see have their plates filled with a lot of stressors and dangers associated with their environment, and we want to try to help them with that. And we have specific notions of how to interface with child protection and sometimes police to ensure the safety of the child, or at least increase the child's safety. ITCT-A focuses a fair amount on psychoeducation, conveying to the young person the prevalence of the problems that they're facing, potentially what might be the reasons why someone would hurt them the way that they do, cultural myths around rape myth acceptance or acceptance of interpersonal violence. So there are other things that our culture may be communicating to the youth that tells them that if they're being hurt, that's normative, and that they deserved it or asked for it or whatever it might be. So we try to directly address those myths to some extent. Very important that you normalize the experience of trauma, even substance abuse, in these kids, which is to work with them to not see that this is evidence of psychopathology, but that their reactions are the normal reactions that a kid's going to undergo when faced with overwhelming negative experience. So we both talk about normalizing, the events that have happened, not saying that they're acceptable, but normalizing in terms of their frequency and how it happened that that individual was traumatized, but also in terms of its effects. So we will talk about post-traumatic stress, substance abuse, self-injury, all kinds of behaviors as problematic to the extent that they produce negative outcomes themselves, but understandable coping strategies. And basically the idea is, can we work with you to develop better coping strategies? And then resources, which is sort of the notion of referrals, other kinds of things. I'd like to just make a very brief notion, state something very briefly here about psychoeducation. We don't generally feel that we want to hand people handouts, photocopies of psychoeducational materials, although sometimes we do that. But, the public health literature for HIV/AIDS, for example, has pretty much taught us that if you want to give psychoeducation to change behavior, what you have to do is do it within the context of a relationship, in the context of therapy. So these are not things that we lecture the client on or hand them handouts for so much, but things that we integrate in the context of the work that we do with them, so, and crafting it to their specific issues as they arise in therapy. We're going to focus especially on distress reduction and affect regulation training. The idea here is, and you can see this in other models like seeking safety or other approaches, that the idea here is that it will be important for you to process your traumatic material in some kind of exposure-based methodology, but that may not be something you can do early on because you're overwhelmed. But if we can teach you to regulate your emotional responses, it might be that your flashbacks, your intrusive thoughts and memories, whatever, may not have as much impact on you because you developed a better, what Marshall Lenihan calls affect regulation repertoire. You have a greater number of skills on how to handle yourself if you do get potentially overwhelmed by painful experience. Again, these tend to work in tandem. We don't just work on affect regulation development. We also work on processing the trauma that's producing the distress. But, in an awful lot of kids, they're not really ready to do that immediate processing. They might be ready to do affect regulation training, which is normally soothing and relaxing. It's not producing distressing material during this session. So you just see some of the things we do there. We have relaxation training we do. We're very big on breath training, and we have a whole appendix on that in the back of the manual, I think. We specifically do something called mindfulness-based breath training, so we're teaching kids how to breathe, how to pay attention to their breath, etc. Visualizations can be helpful, imagining yourself in a field or floating on a raft in a river, etc. But we don't use it too much with our more endangered youth because it is actually a distraction device rather than a learning how to regulate device. It's pulling you away from the immediate world, and for many kids that may not be that great of an idea. So although visualization is sometimes used, I wouldn't use it all the time. Emotion identification and discrimination is just trying to teach kids to figure out what their emotional states are so that they can figure out what they can do about it. It also appears to be true, though, that the more you know what your emotional state is, just almost hand in hand comes a greater ability to regulate that state. If you don't know whether you're angry or scared, you may not know what to do about your anger or your fear. So we spend a fair amount of time, some of it's easy, some of it's a little more complicated, in working with the youth to see if they can know what they're feeling. We don't tell them, we work with them to see if they can figure it out. We have something called emotional detective work that we do with the kid, and them trying to figure out what is their emotional state, etc. Mindfulness, I wish we could talk more about it because it's a growing component of ITCT-A and other, obviously, trauma interventions worldwide right now. But mindfulness involves the ability to be in the here and now, in the present moment, without being distracted by arising thoughts and feelings and memories. We attempt to try to decrease your preoccupation with your past and your worry about your future by having you be more present-centered, more focused in the immediate here and now. This tends to produce something that the mindfulness researchers call metacognitive awareness, which is the ability to recognize that just because you're having a thought, just because a memory comes in, just because you got triggered, doesn't mean that what your thought is saying to you is true. It may actually be the arising effects of your history. With kids, the phrase here that you see is one that we often use or kids come up with independently on their own in ITCT-A. It's the notion of just thoughts, not facts. In other words, just because I'm thinking it doesn't mean it's true. Just because I'm thinking that you violating my gang territory doesn't mean that I need to kill you. Maybe I'm just having a thought associated with, why I would think that you coming into my gang area would be dangerous. But more typically, it would be if I'm having a flashback, it's just a flashback. It doesn't necessarily represent reality. If I think I'm in great danger, I might not be in great danger. As kids are quick to point out to us, they may be in great danger. So we're not saying anything you think is irrelevant to your current experience, but just the traumatized people are going to have a lot of intrusive thoughts, feelings, memories, and if they can develop more metacognitive awareness, they can get better at saying, just because this is happening right now doesn't mean I have to actually do anything about it. It doesn't necessarily mean that there's something going on I have to address. I wish I could talk to you more about urge surfing or emotion surfing, but we don't have much time. This was originally developed from mindfulness-based relapse prevention, which is a empirically based mindfulness treatment for substance use. But we use it more broadly with kids about seeing if they can figure out that their desire to cut or their desire to drink or the desire to punch someone out is just an arising emotional state and a cognitive state. And as Kabat-Zinn once said, you can't stop a wave, but you can learn to surf. The idea here is you can't stop the fact that you've had a triggered emotional state, but what if you just responded to that state as an arising state and not necessarily something you have to do anything about? So metacognitive interventions can actually be quite helpful for kids who have a lot of triggered difficulties. Apropos of that, one of the biggest components of ITCT-A is a module called Trigger Identification and Intervention. I wish there was a less kludgy way to say that. If you download the materials, you see we have something called the trigger grid, which is something that the therapist and the client work together on. What we're trying to do is see if the kid can learn to tell when they've been triggered and when they're responding more to a contemporaneous situation. So if you could know that you were triggered, then the moment that you realize you were triggered, you might have a different response to your triggered input than you would if you actually thought it was based in reality. So we work with kids to see if they know what their triggers are, and we spend some time working in that regard. How do they know they've been triggered? We ask them about times they've been triggered and what did it feel like, dissociative experiences, intrusive thoughts, contextually inappropriate responses, etc. And then based on figuring out how they feel when they get triggered, could they use that awareness to cause them to identify future trigger states? And then we work with them what to do about the fact that you've been triggered, what could you say to yourself, how could you problem solve your triggered states so that you don't actually engage in a behavior. Kids, by the way, like trigger identification intervention. I think because it doesn't sound too therapeutic, it has obvious hands-on meaning to them, because a lot of these kids are getting triggered in ways that they really don't want to be in that state, but they find themselves there anyway. An important part of the trigger grid is that we adjust that each time, we spend some time working with them around triggers before they've been triggered or whatever, and then of course they're going to leave us and have a week between that session and the next one. During that week they may have been triggered some more. When they come back in, we don't treat that triggered state they have as evidence of psychopathology. We treat that as a great opportunity to figure out if we can figure out more about triggers and triggered states and how you know that you've been triggered and what could you do about your triggering. So it's actually not seen as the client doesn't come sleeking in the next week saying, I can't believe that I got triggered again. It's more like they come in the next week and go, you know what, I was triggered this way. I wonder about how that can be addressed. And the therapist's compassionate, non-judgmental responses And the continued work on the trigger grid means that that the process feels non-judgmental, but feels very useful to them. And sometimes we say that the trigger grid is a working document, a living document, because it continues on throughout therapy. And sometimes the trigger grid gets quite filled with material. That's why, as you'll see when you download it, you can make it bigger. Obviously, not obviously, but if you look at the modern trauma treatments, there's very little question that for most people, some level of exposure therapy is a good idea for them. Exposure basically just means that we ask you, or we in some sense trigger you by asking you to think about it, or we say something, or we have you look at something that causes you to remember painful material. When you remember that material, it's associated with the current emotional distress. But in the context of therapeutic safety, what happens is that the triggered distress that comes from exposure gets counter-conditioned or desensitized or habituated or whatever you want to call it. The activation of that material causes the client to feel fear in the session or anger or revulsion in the session. But because there's disparity, there's a lack of agreement between what the child's feeling and what's actually happening in the session, those emotional reactions are not reinforced. And as you know from Psychology 101, over time when you fail to reinforce a negative conditioned response, it tends to fade. So what happens over time here is that we ask you to talk about lots of painful stuff. It produces great distress. The distress is not rewarded because you're reinforced because you're in a safe, caring environment, and eventually it tends to fade. We have a little saying there in ITCT-A, what do you get when you successfully process a traumatic memory? And the answer is probably a memory. So that although you still remember what happened, some of the emotionality associated with what you remember has faded because it's been repeatedly elicited and not reinforced in the session. So in contrast, though, to some exposure methodologies, we talk a lot about titration, which is making sure that the amount that the client processes is not beyond what the client can handle. So very possibly a kid who was gang raped in an alley, it may not be appropriate for that kid to talk about that gang rape early in therapy and maybe not in its entirety right away, but instead might be broken up or just touched on for a second or whatever. So we have a much more, I don't know, in a way, permissive approach to titration, which is that you get to decide how much you can handle. You get to tell us when to stop. I will work to try to make you as safe as possible. I will actually stop you if I think you're doing too much. This is often quite reassuring to the client, because if they think that they have to do the work, they may not do the work at all because they feel like it's out of their control. If I say to them, you know what, let's talk about this as much as you can. If it gets to be too much, let me know and we'll move on to something else, or we'll change how we talk about it. In our experience, it actually causes the youth to want to talk about it more because it feels like it's under their control. They don't feel so helpless in the process. We have multiple sources, which means you can talk about anything in the session that's associated with stress. You don't have to pick a trauma and then work on it for a number of weeks, which is really helpful with complex trauma because there may be so many traumas, some of them very early, some of them later, some associated with non-anxiety states like rage or despondency. There can be all kinds of things that the youth wants to talk about and process, and we want them to do that. We're not going to have them develop a hierarchy or focus on a single event to talk about. Really, in contradistinction to some other approaches, we do not see, in most cases, if a kid doesn't want to talk about something, we don't see that they're engaged in a anti-therapy behavior, that they're involved in resistance. We tend to call that self-titration, and by that we mean that the kid is making an assessment internally that it's not in the kid's best interest to feel things that they're not ready to feel. Is this a little conservative? Yeah, it is. We will tend to avoid stuff to some extent. So the therapist can push exposure a little bit, but they're going to basically honor the client's desire to focus on this as much as they want to, but not more than they want to. Does this make therapy a little bit more inefficient? It probably does if you just had one trauma and if you had enough affect regulation. But actually, we believe in many cases self-titration is an empowering phenomenon. It isn't something bad about the client. And we're basically trusting them and encouraging them to be the decider about their own level of of capacity to handle upsetting material. You may have heard of the therapeutic window. It's been talked about. We've talked about in various therapies, et cetera. Just basically, the therapeutic window means at any given time during treatment, what you're asking them to expose themselves to does not exceed their capacity to handle it. So we talk about undershooting the window, which is when you don't ask them to process stuff they could process, and overshooting the window, which is you ask them to process more than they can process. If you ask someone to process more than they can process, they're probably going to use avoidance to try to survive therapy at that point. Not only does that mean that they're not seeing therapy as safe, and that's not good, it also means that it just basically is leading them to a position where processing is associated with distress, and distress won't allow you to counter-condition painful material. If your memory is so upsetting that it overwhelms you, then you're not actually getting disparity. Your distress is, in fact, associated with danger because you're feeling very bad. So we try to control that so that you don't have more than you can handle. Also, avoidance per se, although it's adaptive, it also shuts down processing. So we're always trying to kind of juggle with the client. What's the amount that you could work on that would not hurt you too much, overwhelm you too much, and would not make you have to numb out or shut down or start distracting yourself as a therapist? Talk about intensity control as well, which is basically means that we generally start the session at a relatively low level of processing of emotional states. The highest point of emotional processing should be roughly mid-session, maybe a little before, and then the rest of the session is decreasing the amount of exposure until by the end of the session they're roughly the same level of activation as they were when they came in or lower. Sometimes this can feel a little inefficient too, but what it does is it honors the affect regulation of the person and it appreciates the fact that what you don't want to have is that youth leaving the session in a hyperactivated state and then having to cut on themselves, use drugs, or have sex in problematic ways. ITCT-A also treats relational therapy, a lot of the aspects of having people process memories, but also their relationship with their therapist, the ways in which the therapist is triggering their experiences with early attachment figures and hurtful people in their lives. Often when you think about relational work, you think about it from a psychodynamic perspective, which is fine, but we also characterize this as actually a form of exposure therapy, which is that as the client interacts with a therapist, it causes the client to remember, to be triggered into early memories of being hurt or maltreated, which means that they then activate a lot of distress in the session, which they attribute to the therapist. This is the old version of transference, although we don't use that term. So the therapist becomes a trigger for the client's early abuse or neglect-related emotions and thoughts, which then causes the client to think that the therapist is those things. However, because the therapist isn't those things, there's a disparity between what they remember of their abuse when they were little and how the therapist is relating to them now. What this can do is allow them to slowly process memory in the context of a compassionate, caring, non-dangerous adult therapist. The effect of that over time is the exposure model, which is we're activating distress in the presence of safety. We're involved in extinction. There's some new work that I'm very interested in, a lot of us are, which is we're beginning to understand there's something called a reconsolidation effect in memory work. I'd love to talk about it for a long time, but I'm trying to tell myself right now not to. Reconsolidation appears to reflect the fact that when I ask you to talk about something very upsetting, if you go into it and you get triggered into that emotional state, it looks like there's a golden window of minutes after the time you've been activated when we can, in some sense, change your memory, not by changing the details of it, but perhaps having you talk about something in a safe environment or with the therapist who's helping you to realize it's not your fault, whatever it might be. Then what happens, apparently, is activated memories then get reconsolidated. They go back into memory, but they may go back into memory with new, updated material, either that the trauma isn't as bad as they thought or a new way of understanding it. And so reconsolidation may be a very helpful aspect of exposure therapy in the relational domain by asking you to activate distress and have nothing bad happen so that when the memory goes back into the brain, so to speak, it goes back in with that extra material that, it's not always going to mean that I'm currently in danger. And maybe even I can handle these feelings better than thought I could before. Because we're dealing with youth, obviously family caretaker issues are a very important thing. I would make a proviso here, and it's a very sad thing, really, in a way, but the reality, at least a lot of the kids that we see who are in adverse circumstance, maybe in problematic environments, is that they don't have much access to their families. They don't have much access to their caretakers or their attachment figures. They may have burned those bridges by virtue of their behavior, or their family or caretakers may have been abusive or hurtful to them in ways that cause them not to want to be around the families or caretakers. Often for some environments, the family may be split up and pretty chaotic and in a lot of distress itself, so that it's not really that helpful for the kid. And a lot of parents, unfortunately, will have problems with parenting and being good attachment figures to their kids, which may mean that the kid doesn't view the parent or the caretaker as a place they can go for protection and for attachment connection. So we spend a lot of time on that. Just remember that if you have a 16-year-old kid who may be emotionally emancipated or even legally emancipated, or is a homeless youth who has nothing to do with their family, you're not going to be able to do this in the classical way. But ideally, and certainly for the child version of ITCT, we focus a lot on working with caretakers. We have groups for them to figure out how they can parent better, but also support groups for them. What is it like to raise a kid or be in contact with a kid who's suffering so much? We work to try to make sure these aren't complaint sessions of my kid's so bad, you won't believe this story, but more like, what is it like to have to be present in situations where someone you care about is in great pain and is causing problems for themselves and perhaps you and others. So it's a true support kind of notion. We focus on family therapy to some extent. Family therapy is a special kind of family therapy, though, which is it's especially focused on how can the family be a better resource for the child, how can the family learn to take care of each other in more positive ways, how can the family learn to decrease their triangulation or their scapegoating or whatever, which will often involve your client. So it's a form of family therapy. You could call it perhaps trauma-focused family therapy. So when you access that chapter, if you do, you'll note that some of it looks like regular family therapy stuff, but the effects of abuse within a family, the response of family members to a kid who's been abused outside the family, kids' problematic behaviors with substances or aggression or sexual behavior, may put great stresses on the family and may require a different kind of set of interventions than we normally would do. And then this one's rough because what agencies can reasonably do this, but we do recommend it. It can be very helpful. If we can work with the individual in some kind of individual domain or refer them out for someone else to help them, a lot of our parents have such painful attachment histories themselves that they're really not able to sustain positive, caring, reliable connections that are empathically attuned with their kid because they have the intrusion of their own material, etc. So what we want to do is see if we can work with them at least to recognize that the problems that they might be having, as well as perhaps helping them to resolve them. Sometimes this involves couples therapy, where, as you know, the couple's difficulties are playing out in their behavior with the kids, and it may mean that if the parents could get a little bit of a handle on their behavior, ways in which they're triggering each other, etc., they might be more benign in their relationship with their kids. All of these interventions, though, I would say especially are focused on the kids. So it's a little different than a family therapy approach that's focused on the whole family. It is focused on the whole family, but the goal is to make the family more benign, more of a source of support, make the parents better attachment figures, and see if some of the cycles of punitive behavior or controlling behavior that the parents are using to try to handle their seemingly out-of-control child, whether they can figure out other ways of doing that that have fewer negative side effects and may, in fact, return the family caretaker environment into something that's helpful for the kid instead of an additional stressor for the kid. So the last thing we can talk about here is substance use and abuse. This was a very big part of our funding mission with SAMHSA originally for this. We're involved in a multi-year grant to provide ITCT-A to socially marginalized, multiply traumatized, typically inner city youth. although it's been used in higher socioeconomic and more privileged environments as well. And SAMHSA, by virtue of the initials in their name, were very interested in trying to deal with substance use and abuse with this population. So we've taken that seriously. We try to spend a fair amount of time working with substance-using youth. By the way, we say use and abuse because, first of all, and DSM-5 sort of acknowledges this, it's pretty hard to figure out what the demarcation line between use and abuse. But the other big issue is even if the kid is not technically abusing drugs, they may be using it enough that it's producing problems for them, either in decreasing their ability to process trauma or encouraging them to engage in situations where they might get hurt or where they might hurt others. So not every kid's going to need substance use and abuse interventions. And in your environment, it may be that only a minority of kids are going to need that. But in some of the environments we work, homeless youth, et cetera, almost everybody is going to need assistance with that. And you see there the link to the project website where you can download that manual. We focus a lot on safety assessment, which we talked about before for any multi-traumatized kid. But kids that are involved in substance abuse are at much more risk of being victimized by others. And so what we want to do is see if we can increase safety and stabilize the situation. It's a very sad thing to see a 14-year-old girl who's been multiply victimized in her life and is now using substances in a major way. You can sadly almost predict she's going to show up in your emergency room or trauma center with a sexual assault or something later on because she's using substance abuse to handle her distress. Unfortunately, it's also making her vulnerable in a predatory environment. So we call this sometimes the vicious cycle of substance abuse, which is this, you're traumatized, you use substances to decrease the distress of trauma, but then that increases the likelihood you'll be traumatized again, which may mean that you then have to use substances further. I think a bunch of people are showing this right now in treatment outcome studies, including one that just came out very recently. It does not appear to be true, the old adage that you want to treat them and get them better and then, you want to have them get substance abstinence and then treat them. It does not seem to work that way. So the old idea that they need to be substance abstinent for like a month before you start treatment, I wish that would be nice. That would make it easier, but realistically, resources for substance abuse treatment out there are not very good, especially for socially marginalized youth. And also, frankly, if you don't work on trauma, it's pretty hard to treat substance abuse. On the other hand, if you have a traumatized substance abusing person, it's going to be pretty hard to work on trauma unless you process the substance abuse issues. So we recommend the simultaneous interventions both in the substance abuse problems and the trauma problems. Again, I would refer you to Seeking Safety, which is very, Lisa Najevitz's work is very consistent with ours. In fact, she was a consultant to this grant in terms of trying to figure out ways in which we can both work on the substance and work on the trauma at the same time. That's a big deal. So if you're working with a kid who's acting out and is high most of the time, that means that it's going to be very hard for you to help them because they're going to be titrating their experience of you, and they're going to be shutting down a lot. They're going to come into sessions high or cycling through very dramatic and strong emotions associated with their substance status. And you're going to want to not treat those kids. But frankly, if you eliminated every kid from your caseload who had substance abuse and just tried to treat the pure trauma cases, it probably would eliminate a good portion of the people you work with. So we recommend, as you'll see in that manual, working with both of those things at the same time. Lisa's work, we talk about remoralization, which is a lot of these kids are very demoralized by the fact that they've not only been traumatized, but substance abuse means that they may be in more difficult environments. They may do things they wouldn't normally do. They may be very desperate. They may feel very badly. Substances tend to move in a downward spiral, so you tend to feel very bad about yourself and have even fewer resources. You may have sold your mother's television set, so she won't talk to you anymore. You may have, just a million different things going on here. What it functionally does is it demoralizes the kids. So we suggest you try to work with them to remoralize, which is to see if they can figure out ways in which they have helped people out there. You don't want to lead the witness here, but you can usually help them find ways in which they still are trying to behave in some level of morality, if you want to use that term, some ways in which they shared their hamburger with another drug addict, or sometime that they listened to someone who, in the depths of an alcoholic despondency, they were there for them as a friend or whatever. You can often find those things. We also, obviously, talking about empowerment here. Can you not see yourself as the passive victim of substance abuse, but instead that you've been using substances as a logical and understandable way to deal with pain? The only problem is it has so many downsides that we would recommend you try to do something different. So these kids are not being told that they're bad for using substances. What they're being told is that it's logical that they're using substances, but the problem is that creates new problems. Could they figure out a way to use substances less and use them in different ways if they have to use them, etc. And you'll see that this is a little bit like the harm reduction algorithms we see in classic psychotherapy. We'll be working with them to see what's the most you can do, how much can you cut down, how could you not, when you know you're in this situation, could you keep from getting high when you're going into the situation, etc. So a lot of this, the locus of control, is being brought back into the previously demoralized person who feels that she has no power, instead providing her with opportunities to see her own involvement, not in a blaming way, but in a way that tells her that she could do something different. Exposure therapy is still going to be helpful even with these kids, but obviously if they're using substances, that means they probably have low affect regulation, so they probably can't handle as much. Also, if they're prone to going into substances as an avoidance strategy, you could very easily trigger them in a session, causing them to use more substances afterwards. This is why a lot of 12-step programs don't want their people in your treatment program, is because they're afraid that you will trigger them and get them to drop their abstinence because they now have to use substances to survive psychotherapy. So what you want to do is have slower, less intense exposure treatment, a lot of attention to the therapeutic window, but don't give up on it. I think a lot of people think, oh, my client could not handle any processing of the past because they're a heroin addict. Those are not actually consistent. They don't make a lot of sense, those two statements. It's true that they're a heroin addict, and it's also true they can probably do some exposure. The issue is how we titrate it, how we control it, how we make sure that the amount of distress that they're processing is not going to require them to use substances after the session as a way to deal with it. A lot of attention to affect regulation skills. Can you learn mindfulness? Can you learn breath training? Can you learn how to calm yourself down? Can you learn to identify your emotion? Can you address catastrophizing cognitions you have that tell you that there's nothing you can do and cause you to have a very dramatic reaction? So we're going to work with those things to try to have you be better enough at your emotional regulation that you don't need to use the substances so much to accomplish that goal. And then obviously a lot of times people talk about a confrontation in the older therapies. You don't have to name them, but a lot of therapies you sort of are telling the client, that they really need to take responsibility for what they've done, and they need to make amends for all the people they've hurt, and that they really need to snap out of this, and they've really done something wrong, and they need to take stock of themselves, etc. I mean, I understand the thought behind that, but we really try to avoid confrontation. Generally, if you become strongly negative or judgmental with your client, that's going to cause them to leave therapy or not trust you as much or avoid you more, or maybe try to learn they're going to work to try to figure out how to please you or do what they think you want them to do, which usually just means that it drives therapy underground. They're not going to stop using because you tell them to stop. They're just going to stop telling you about it. So we really try to focus on a non-judgmental approach to this work. And this is somewhat controversial, but I don't really think it has to be, which is to work with them to see that actually substance abuse and use is a coping strategy for them. It's not getting them off the hook. It's not justifying the behavior per se. It's just saying what you're doing is logical. So from a logical perspective, what else could you do instead, since substance abuse seems to be producing problems for you? Here's just a little, hopefully, no, that's not working. Okay. There we go. This is a treatment outcome study. Again, I want to say as a methodologist person myself, this had no control group, primarily because the environment, the neighborhood that we did this work in was very, very impoverished, very high violence, one of the more dangerous cities in the United States. We had very alienated youth, hurt youth, many acting out behaviors, et cetera. We did not feel that we really wanted to have a control group who didn't get the treatment or got treatment as usual or got some other version. We really felt that we owed it to them to give them the full force treatment right up front. Doesn't mean that I don't think we can do this in less severe environments where we have a control group, but there's no control group here. So those big differences between pre, which is in the sort of purpley color, blue color, and post being the maroon color, those differences, you could say, well, maybe over the process of a couple months, they would have just dropped those symptoms that far anyway. In the treatment outcome study that was published on this, we tried to statistically look at what the likelihood that that's what that was due to. Of course, you can never rule it out. However, having said that, what you see here are 151 kids, most of them adolescents, some younger, because we use both methods of ITCT, the adolescent and the child. How much did they change on anxiety, depression, anger, post-traumatic stress, dissociation, and sexual concerns? And we're looking at about a 40% drop in symptoms, which is really a very large effect size and was very encouraging. So, you know, sometimes if we had more time, we'd look at some of those differences are bigger than others. We know that sexual concerns doesn't respond as quickly as other kinds of problems do, but post-traumatic stress, for example, is a pretty dramatic effect of being an ITCT-A. And then I think then the next slide is just some references, which you have in your handout. So I think we're done if you want to take it to the discussion component now.
Absolutely. We do have questions coming in already, and we'll try to get to as many of them as we can in this 20 minutes that we have for questions and answers. The first question is, I have a young lady client, age 22, a sexual who has researched for 2 years prior to engaging in BDSM lifestyle. She experiences it as empowering. I think this lifestyle choice may be a growing trend, reference to 50 Shades of Grey, and am not sure how to handle this issue.
Well, I congratulate you for thinking about it, because it is one of those sticky wickets out there, and it is running against a lot of different countervailing feelings and theories and social responses. BDSM, for those of you not familiar with the term, refers basically to individuals who are involved in bondage or in domination or in masochism, so-called. Basically involves using the sort of things that you may have seen in the movie Shades of Grey. I guess, you know, on one level, what people use in their sexual relationships with others really shouldn't be our concern, as long as it's not hurtful to them or to the other person. And so we do see, and I published several papers actually on how sex abuse survivors do have more force-focused or dominance or submission-focused fantasies and potentially behaviors than maybe other people do. So it is potentially an effective trauma, but it may not be in all cases, and different communities may have different standards of you know, what is acceptable in that regard. You can't talk people out of what their sexual proclivities are. If she's been spending all this time thinking about it, it's probably something that she's going to be involved in or already is involved in. You know, our general approach to that and related problems is to be a non-judgmental, supportive person who encourages them to talk about it as much as possible from a perspective of what about it is what feels good for them, is useful for them, how it might be addressing the trauma, and then what are the downsides, and including whether it puts you in greater danger or it reduces the chance that you'll be able to recover because it's involving some kind of an avoidance. A real key thing for any of these sort of potentially shameful behaviors is the therapist really needs to be a loving, caring, wise, older adult who can hear anything, including sometimes fairly shocking BDSM stuff. I've heard some doozies, without immediately becoming judgmental towards the youth. Because the minute that you say, well, look, that's just not acceptable, they're not going to tell you about it again, and they're not going to tell you about it as much, or they're going to basically fudge the data and say that they don't do it anymore when they still do. So this is, you know, you have my compassion, and I'm glad that you think about it this way. What you're wanting to do is is respond in a way that allows them to talk about it as much as they can, within the constraints of what they need to talk about. But then also work with them to see if they can see the potential downsides, and that they can understand what might be concerning for you without them thinking that you're now someone who needs to be managed because you're upset about their behavior. We also see this in prostitution. So it's a very balanced and difficult issue. I do think, and I've gotten some grief for this, I do think that extreme BDSM is an abuse phenomenon. And as such, it needs to be addressed as such, but you can appreciate the complexities of that, especially given the fact that we actually have movies about it, which I have no objection to, although I wouldn't see the movie. It's just that what that is doing is telling vulnerable people that that is something that maybe they're being coerced into, which is not that uncommon, and actually isn't a very good idea for them.
Okay, could you also then talk about at what levels of care can this be implemented, and then also addressing outpatient versus residential treatment?
So ITCT-C, the child version and the adolescent version, have adaptations for different groups. The primary focus here has been an outpatient approach, clinic-based approach, which seems to be pretty helpful. But we have a whole school module, especially for ITCT-C, but also ITCT-A. Well, I guess it's roughly equivalent for both, where in some cases, we go into the schools and all the treatment actually occurs within the schools. So you want to look at the manuals around how to get buy-in by the schools and how to make sure that you're addressing what their concerns are, because you're going to have the kids be taken out of class or be doing things in different ways than they normally would. Trauma-informed education is a whole issue about how can schools be non-traumatizing or shaming of kids. So it's definitely the school-based function. We even have a sort of a sub-module for what are called storefront environments or alternate education environments, which are usually kids that are in such bad trouble that they can't even be in regular school systems, and so they're in these special programs. So we do have adaptations for that. ITCT-A is now being used. I don't know if anyone on the line here is one of those people, but it's being used in residential treatment environments as well. So that is possible. It's being used now a little bit with kids who are unaccompanied minors associated with immigrants from Mexico into the United States. These kids are coming across the border with lots and lots of problems that made them come across the border, as well as how they're treated at this end. And the government has all these sort of shelters for them as they come across the border. We're actually working with some of those shelter people to see if ITCT-A can be adapted for that. I think we're fairly successful. A big population I wish we could do more for is the homeless youth. The issue here is often they don't come more than once or twice, so it's pretty hard to, or they come sporadically, it's pretty hard to do a structured program like ITCT-A with them. We are trying to work on that, and there's some really great programs like Children's Hospital LA and other programs that are working with homeless youth, and we're really trying to work out adaptations. But some of the problem there is that if you only see the kid twice, how much of this actually can you do? We have some advice for what you can do, but it's obviously a problem.
Could you talk a little bit about eating-related problematic patterns such as bulimia?
So generally, from this perspective, we do see binging and purging as tension reduction behaviors. There's a pretty strong literature for that. First of all, the literature shows that although anorexia per se is only mildly associated with trauma, it's more associated with family roles and perfectionism and other kinds of things like that. Bulimia, binging and purging, is pretty strongly associated with chaotic families, child abuse, child maltreatment in various ways. And binging, purging is probably two tension reduction behaviors in one. You're eating to try to soothe yourself, and then you're purging to try to deal with the self-hatred or disgust you feel while you're eating. So binging and purging in the course of adolescence, this is a big deal. It's right in the middle of the bailiwick of ITCT-A. We talk about it. It's one of the assessment items on the ATF. We take it very seriously. The problem, of course, with a lot of these sort of socially unacceptable behaviors, you've got, as we mentioned earlier for BDSM, you've got to find that way that you're being accepting and supporting enough that they can talk about the issues they're struggling with, but not saying it's just fine even if it's hurting you. We want to try to work with kids to see if they can identify what the problems are, and almost from a motivational interviewing sort of perspective, say, if you know what the problems are, what's keeping you from being able to help with the problems? So it's a benign but and accepting model, but it does focus on the fact that things like benching and purging have a lot of negative downsides, including actually, in severe cases, potential death through cardiac failure, and in the intermediate levels, all kinds of gastrointestinal problems. And so it can be a pretty big deal. It's very stubborn and non-responsive to immediate treatment. So what we tend to do is see this as a longer-term problem that we will visit and revisit in therapy sessions.
Have there been any studies that explore the use of ITCT-A with human trafficking victims?
That's a specific interest of mine. I can't say that there's studies on it, but if you look at the manual, you'll see that it's replete with issues around kids who are stuck in situations where they're being used sexually. Some of us in the broader trafficking area see kids forced into prostitution or stuck in prostitution as being trafficking as well. It's just local trafficking. The issue of sex trafficking is huge. There are programs involved in it who are experimenting with ITCT-A right now. We don't have an actual treatment outcome database for them, but I have to tell you that those kids are often in sufficient distress. They know pretty clearly that they're being hurt, that their buy-in for an intervention that doesn't blame them but tries to give them hands-on coping strategies and pragmatic solutions to their problems can be pretty helpful. On the other hand, if the kid, for instance, believes that their behavior is empowering to them, that they're the one that's in charge, and the client or the John or whatever is actually the poor schmuck who's paying for their services, when you run into those kinds of issues, it means you have to tread very carefully, because you don't want to say to the client, no, actually, you're being abused. You don't have any power in the situation. And we're focusing on empowerment. But, you have, on some level, we have to appreciate the fact that these kids are not, in fact, empowered. What they are is being given a delusion of the belief that they have control over the ways that they're being victimized. So I really like the question, and I hope people try to use this more in sex trafficking because there are not a lot of interventions available for that cohort, and it's obviously a very large cohort. Our desire to look the other way to the side, the reality is that many kids who are homeless or in very serious economic or social circumstance are involved in some kind of maltreatment by the sex industry, whether it's being sent to another place, and we can talk about that a lot in terms of how trafficking affects kids, or whether it's occurring in their own neighborhoods.
Okay, I think you touched on this a little bit regarding the abstinence from substance abuse, but for outpatient youth, what is the criteria to establish safety before moving on to other phases of treatment, e.g. no self-harm, no active abuse, no dangerous community, etc.?
Yeah, so that's such a smart question, and it's such a real problem. And, it's a dance more than it is a therapeutic intervention. What you're wanting to do is not deprive them of treatments, including exposure and cognitive interventions and other things, affect regulation training, that might decrease their involvement in these behaviors. But on the other hand, what you want to do is make sure that safety is the primary focus and that you don't ask them to do more than they can handle at any given moment. So we spend a fair amount of time focusing on safety, but, it's also true. The reality is that these kids are not going to stop doing methamphetamine because you ask them to, or because, it's serving a function for them. They're not going to give it up very easily, which means they are going to be in continued danger. So we have this problem, right? We want to increase their safety, but we also, on some level, know that unless we get some inroads into the treatment process, that's going to help them with their safety. So, what we would recommend is every session there's a focus on safety, and it's interdigitated throughout the session. But on the other hand, that's not all that it's about, because it may be that they can't stop using until they get some tools that will help them with using. Learning those tools may mean that they have to be introduced to therapy processes while we're also trying to increase their physical safety. My hat is off to all of you who are working with this group, especially in more desperate circumstances. How do we keep them safe? How do we work on the problems that are creating the situation where they're not safe?
What is the typical length of treatment and the range thereof?
Okay, so in some environments, these kids may only get 3 or 4 or 5 or so sessions. And with homeless youth, sometimes 1 or 2. The average treatment for most of the work that we've done for the treatment outcome study would be 2 to 4 months. which isn't really a very long time if you think about it, but certainly some kids who have major attachment problems and all kinds of symptoms in a wide variety of areas, who have some social impairments in terms of what's blocking them from getting the help that they need, in terms of impediments more than impairments, means that they may need to be in therapy for longer periods of time. So clearly we have had kids who've been in ITCT-A for 2 years. The idea here, though, is something that methodologically I've tried to talk about as something called extendability, which is if you have a 12-session program, what happens on week 13 if they're not better enough? So the idea of a program like ITCT-A is that it's open-ended in terms of how long it will take. And the amount of time it will take is probably a function of how much help they need and how much they can handle being in therapy and how much the social system will allow them to do that. So it's widely variable. But probably the average person would be 3 months, something like that.
The next question is, how is treatment different with offending versus non-offending caregivers?
So this is a sticky wicket again. What is an offending caregiver? So we've kind of made the decision that if you sexually victimize your kid or they're at risk of you sexually victimizing them, then you are not involved in treatment. So this is not a family reunification approach. It's an approach of working with what's available but not asking kids to be in sessions with their perpetrators. And I know there's controversy about that. But what we want to do is work with less offending parents. So, you know, if you've physically abusive to your kid and it's been reported but you're not being adjudicated, it might be that we will keep you in therapy to, you know, if we don't think the kid's in danger, but that's going to be the critical issue. You could say that the parent who doesn't care and is allowing their kid to be heard is also an offending parent. So it's a very difficult thing. We do have a hard, fast rule, though, that if it's any kind of sexual victimization or if it's severe physical victimization that involve criminal justice, then probably those people need to not be involved in the therapy process. It doesn't mean they can't be helped in their own worlds, and I have compassion for them as well. What they're doing comes from their own histories and experience as well. But we generally don't think it's going to be very helpful for the kid to be involved in that work with them under those circumstances.
We have one more question, it looks like, and then if there are no further questions, we'll close after that. It is, has ITCT-A been used to help youth? So I'm trying to reread the question. Has it improved intimate partner relationships? More specifically, has all or part of ITCT-A been used to reduce use of violence and aggression with dating partners?
No, we have very little information on that. Anecdotally, I think any therapist could talk about ways in which they've worked with people whose violence against their partners or others was clearly a result of their abuse, and then when they worked in their abuse issues, some of that violence decreased. I personally, because I've also worked in offender domains, believe that in many cases working on trauma won't be sufficient to stop someone who's now got an ingrained pattern of violence or sexual victimization against others. They need their own specific focused treatment. So I probably, if I saw someone who was very involved in the use of coercive or aggressive interactions with their sexual, romantic, or relational partners, I would probably think they need additional treatment outside of the domain of ITCT-A. On the other hand, does that mean that we don't have lots of kids who are somewhat problematic and engaging in behaviors that we wouldn't want them to engage in with other kids? Yeah, that's definitely true, and we're not going to just shift them all off. So I think you can do what you can do, but therapy is always the art of the possible, and ITCT-A is doing so many things that it may be that kids who need focused attention to offender-level issues may need additional or separate treatment in some other way.
There was just one quick comment, a reference to EMDR. The person says EMDR uses reconsolidation regarding beliefs about self that become unfrozen and accessible to adaptive changes. Do you have any comments about that?
I wouldn't disagree with the statement. So it's not like we're saying EMDR versus other things. Some people use EMDR in ITCT-A in terms of processing traumatic material. Reconsolidation is probably an active ingredient in any exposure-based or cognitive or emotional processing algorithm. So it may be actually just one of the core effects of trauma treatment. I don't know if we want to go that far, but it looks encouraging that way. And any treatment like EMDR that would explicitly identify that as something they're doing has probably got a leg up in that process. It's just kind of an exciting new idea in a way, although some people have been talking about it for a while, but it may be that when you activate emotional material and a traumatic memory, you may have a little chance to do some work in the next little while that may cause the person to actually have a changed associations to the memory. And that can't be anything but wonderful.
All right, so I believe we've come to the end of this webinar, and I want to thank you, Dr. Briere, on behalf of ISTSS for your excellent presentation, and also want to thank everyone for attending and for your great questions and participation.